Thanks to everyone for joining our Q&A session today. I'm Mo. We've got Professor David Jones with us today. Thank you again for joining us. You're a regular. You're very much a regular. And these sessions continue to be as popular as ever. And we still receive so many questions every week. Really, it's still... I'm trying to think how long we've been running now, because it was just at the start of COVID, wasn't it? And
it was kind of just at the beginning. It was trying to keep everyone in touch when it was getting, when people were getting a bit isolated. So we did the Thursday, they started out as talks with a Q&A at the end, and then we just became Q&A, and then the sort of other Facebook meets. And I think it's been one of the most, as I've said to everybody, we all enjoy doing this. You can tell that. I think they are incredibly valuable. People are very nice about it. And after all these years, we're still getting really good questions about issues that haven't been raised before. And of course, the sort of these 5 years have been a time of enormous progress with the therapies. And it is a really good vehicle to be able to update people about that, because it is very much a moving landscape. And so I think it is very useful like that. So I can't see us stopping doing them anytime soon, can we?
No, we are making a little change though, and I did want to just talk about that today if we can. So we always, at the beginning of our Q&As, we always make the disclaimer about these don't take the place of a consultation with your own clinician, and that we're aiming to provide general medical information and not medical advice. And we have had some feedback from some of our people who watch on Facebook, is that there is quite a lot of personal medical information sometimes people share on Facebook, and that is a public forum. So what we're hoping to do, starting 4 weeks from today, which I think is one of your ones, Professor Jones, as well. We're going to be moving over from streaming it live on Facebook as well, and just having it in the room here. And that's really just to make it a bit more of a safe space for people. The method for submitting questions remains the same. You can do that through our website, contact us, send us in a message. And what happens when we record here in Click Meeting, the section on the right, which is where the chat is and where we can see chat coming in from patients that have joined us, that's not shared, it's just on screen. So we'll be able to make it a much more safe space and a much more private space for patients to be able to ask questions. We will, of course, still upload them to our YouTube channel, so they'll all be available for people to watch. It's just that we will start transitioning it from Facebook Live in the next 4 weeks over to just Click Meeting. The service is obviously still free, because joining the foundation is free. We will get to the point where we will put the link for the Click Meeting behind our logon on our website, and that again is just a safe space to protect our members. And their online safety is really important to us, so we've got to make sure that we're getting that right and keeping people safe. So that was just a wee update, and I'll mention that each time as we're moving forward in the next 4 weeks. But in terms of the Q&A itself, the format, how the doctors attending, all of that remains the same. It's just the method, one of the methods of delivery we're changing slightly for.
And I think the way I do it, and I'm sure people do it differently. I think that's probably one of the attractive things, is people do it in a different way and a different approach. But there's always something when people tell a story, ask a question about their own experience, there's always something in that which is relevant more broadly. And what I try and do is sort of pull that out, just tease that thread out. And so hopefully that is, very useful, specifically the person who's asked it, but actually it becomes about, I call it the peg to hang something on. And so that's just my way of doing it. So, and the caveat, just as Mo says, is that we can't be a replacement for your own clinicians, but we can help guide your conversations with them. Mm-hmm. And the main reason for doing that is that obviously we don't see the back information. So, when somebody comes to see me in the clinic, you will have a huge amount of information from the systems about it all. And, in a sense, we're flying a little bit blind with regard to all of that. So that's what the caveat with it is, that we haven't seen all the previous tests and things like that. The things, so that you just have to caveat a little bit.
Yeah, and I always say as well, if sometimes when we get questions in, we do refer them over to the helpline because we feel they're a bit more appropriate for that. And just to say that the Q&A isn't the only route to get information in and information back from the foundation. If you do need a bit more detailed information, we're absolutely here on the helpline to do that for you.
And actually, I'll be honest, that I've started seeing in the, so we'll see in our NHS clinic, anybody from anywhere, talk to your GP about being referred if you feel it will be useful. But I'm starting to see people who've actually, dialed into these, spoken to the helpline, realised that kind of it could be a little bit better, a little bit tighter, and have actually asked to be referred. And the GPs have been very helpful with it. So, that's the system. So GPs often say, "Are you prepared to see people from out?" I'm an academic. I'll see anybody from anywhere. Anybody who feels that it's worth the journey to come and talk to us, we'll happily help. So, but the key is to get the GP, and usually the magic thing to say is that you want to take part in the research studies, and that GPs seem very sympathetic to that. And remember, I shall say this: the NHS constitution. The NHS has a constitution, and one of the things in the NHS constitution is that all patients have the right to participate in research. Okay, it's a right, and all you're doing by asking to go to a centre that does research, and there are a number of them around the country, is you are exercising your right. You're not asking nicely, you are saying it's my right, and just remember that.
Yeah, and often we can be, as patients, we're not sure how much we can ask for, and when we can say, is it possible for a referral? So we're here to support anyone that needs some help to do that as well, if you feel that you're not being monitored correctly or anything like that. Right, over to our first question. So we've got a patient who's had a kidney transplant 2 years ago due to lupus since the age of 11, 58 now, and after transplant the liver tests were high. They have been returning to normal, but the doctor did a biopsy last year which showed inflammation of the bile duct. She also did an AMA test at that point, which was 30 and diagnosed with PBC. The question is, could this have been caused by the transplant or potentially their anti-rejection medication?
No is the short answer. So there is no connection between renal disease or renal transplants and PBC. So I don't think so I always apply our 1,000 patients test. So I think Newcastle, we've got a little bit over 1,000 patients. So if we haven't seen it, it's not common. And I don't think we see anybody who's had a renal transplant, or at least that hasn't dawned on me, the group that I see. There are 3 of us, and so we see different people. And immunologically, it wouldn't tend to. Okay.
Mm-hmm.
So what about those things that are around transplant? Well, without getting too geeky, there is a thing called graft versus host disease, which is where there are sort of white blood cells that hitch a ride, if you like, with the organ that's being transplanted, and can cause some damage in the body. And one of the areas that those cells can cause damage is the bile duct. So now I'm not aware of anybody, I've never seen anybody with graft versus host disease after a kidney transplant. We see it most commonly after a bone marrow transplant, but that's kind of predictable because the bone marrow is full of white cells. And you see it very occasionally after a liver transplant, actually, very, very occasionally. And I think we've seen 2 in Newcastle in 10 years. So, but neither of those would cause AMA to be present. Okay, so it might cause the bile duct to change, but it would not cause the AMA. So therefore, it sounds very much like this is PBC. And actually, we know that, there are various different drugs that are used for prophylaxis for a renal transplant, but tacrolimus, cyclosporin, in the old days, and obviously azathioprine, MMF, those are all drugs that have been used to treat PBC. Okay, so they're all drugs that are probably slightly effective for PBC, but they aren't effective enough for us to really want to use them, entirely for that. So I think they're unlikely to have caused PBC. There is a slightly odd thing about recurrence of PBC after a liver transplant. Recurrence of PBC after a liver transplant, which does seem to be commoner if people are taking tacrolimus versus cyclosporin, which is the drug we used to use. Okay, now that doesn't impact what we do clinically, and I don't think the recurrence of PBC after a liver transplant is enough should factor into anybody's decision about a liver transplant. It's kind of peripheral to it all. It's conceivable if that sort of effect is there after a renal transplant and somebody's on tacrolimus. It's always not impossible that that's part of it. But I suspect these are two sort of separate processes. And if anything, probably the immunosuppression has slowed the onset of it. What do you do with it? You do exactly what you would do for anybody with PBC. So you go back to the basics. So ursodeoxycholic acid, that absolutely won't interfere at all with the renal transplant. And then you would use one of the additional therapies, first line, second line, therapies as you would do. What differences might I make? If this is way down the line, but if you did need second line therapy, I might avoid bezafibrate because it can cause renal problems. Obeticholic acid, like all of these drugs, has its strengths and weaknesses, but it never causes renal problems. So we would just treat this exactly as we would treat anybody else, but maybe just have half a thought about the blood test. So I think these are probably two separate things.
Great, thank you. Question about, what are your thoughts about low-dose naltrexone to treat the symptoms of PBC?
So naltrexone. Naltrexone is an opiate antagonist. Okay, so it blocks the actions of opiates. And you might think, what on earth has that got to do with PBC? Well, if anybody who's had a opiate, infusion after an operation or something, will tell you they can cause you to itch. Okay. I have to say that when my wife was having a cesarean section for our first child, she had an epidural put in, and she started scratching her nose, and I said, "Oh, that's just quite extraordinary." She said, "What, you mean having a baby?" And I said, No, you're scratching your nose after an opiate epidural. It proves that opiates cause itching." So you can imagine how that went down. So
yes,
opiates cause people to itch. Okay. Now, what's that got to do with PBC? Well, sick bile ducts in PBC produce natural opiates. Your body produces opiates naturally, to control pain, and the bile ducts that are sick produce that, and that's thought to be one of the contributing factors to why people get itch with PBC. Opiates are produced by the bile ducts, and then they work on the receptors in the skin that would sense it, opiates normally. Okay, so that was the theory, and so therefore, if that's the case, then you can use naltrexone to block the actions of opiates. It's something we do. Okay, it's fairly low down our list of treatments for itch. The reason for that is that in our experience, it either works really well or not at all. So it's a bit Marmite as a treatment. But when it works really well. And then the other thing is that rather as if you suddenly sort of stopped taking opiates, you get opiate withdrawal. People, for want of a better term, go cold turkey if you suddenly block opiates. So they can get sweats and pain and shivers and nightmares and things like that. So it can be quite difficult to start. Okay, so it's not one to chop and change with, but it's something we certainly do use, and where it's effective, it's very effective, but it's pretty low down the list. Okay, the way around that would be to use very low doses, very, very low doses. But the problem is the tablets are 50 milligram tablets. You can, buy a little guillotine off Amazon to cut tablets, but you probably can't do more than quarter them. And those are probably, it's too big a dose to start with. Now, we talked about research, and one of the things in research is trials of new drugs. And actually, coincidentally, for somebody asking this, there's about to be a trial starting in the UK which looks at a new version of naltrexone. So it's the same principle as naltrexone, but rather than it being a tablet, you pop it under your lip, a bit like nitrates that sometimes people take. Okay, but the other thing is that they produce it in a variety of ultra low doses. Okay, so it's very user friendly. So you can use it at whatever dose combination you want. Now, Will that make a difference? It seems to be a step in the right direction. We haven't used it in anybody yet. The trial hasn't started. I think actually Robert was talking to the company this week or next week about it to find out more. To me, it's a smart thing. It's a better way of giving a drug that we know at the end of the day works. So keep your eye out for that. It's kind of, the drug will work because the drug works. The question is, does it make it easier to use? And it's got to be a step in the right direction. So keep an eye out for that. So like nitrates under your lip, basically it allows you to adjust the dose and start with a very low dose. But naltrexone, we've got a small group of people on it. They swear by it. We use it occasionally, but it's down the list from other things, but we definitely use it. What it does is give you get very strange looks when you go to the chemists, okay, to pick up the prescription, because its only two other uses are for people with alcohol withdrawal and people who are stopping heroin, right? And so, and then PBC. So pharmacists tend to give you a very strange look until they realize what's going on. So if you do get that, don't worry. But it's a small print treatment, but like it's the sorts of things that we use when we're working our way through a complex situation. So it is far better for us to have access to these things than to not have access to them. But it's not an early choice in the ladder. It's quite late.
Yeah, it's something that personally I tried when my itch was really bad, and it's really good to hear that they're looking at the lower dose, because the dose was quite brutal. It was quite difficult. Your body does go through withdrawal, but the potential was, if you can get through that, then it'll help. And if that was the case, then I was prepared to try that.
So just out of interest, did you get over that? I mean, did that wear off? Because we sometimes see people, it just doesn't wear off.
I was on it for about 3 weeks, and the symptoms were really difficult, so I stopped it at that point. But I did try it again before I went to the transplant route, and the same happened again. So any medication that I had tried, we almost tried everything again, if you know what I mean, before we went to the transplant, just to be sure. But the naltrexone, out of everything that I tried, was probably the most difficult one that I found to take.
And that's not uncommon at all. But this idea that if you could start on 100th of the dose, if you like, in a very accessible way, you can see how that might work. Absolutely. And you're not just it's not just kind of starting with a low dose and then build it up. To do with the pharmacology of how it works, that starting on very low doses is effective. And naltrexone would be fine if they just made smaller tablet dose sizes.
No, that's really good.
But it's like the old saying about aspirin after a heart attack. So many people will be familiar with taking aspirin after a heart attack, and the question is, what's the right dose? Because of course aspirin for headaches is a completely different dosing for aspirin for blood clot protection. And I once heard an expert on this talk about what the right dose is, and he said you want to keep an aspirin tablet in the bathroom cabinet and take it out and lick it once a week. And so we need a sort of licking it once a week equivalent of naltrexone.
No, it's good to know that they're looking at that, though. That's actually interesting.
Yeah. I mean, remember, we all tend to think about clever new drugs, but that's what is called pharmacology. So pharmacology is the science of new drugs, and pharmacy is the science of how those drugs get into people in a way that works effectively. People tend to focus a lot on pharmacology, but actually, a lot of the wins in the real world are through better pharmacy. So, for example, think of a tablet you can take once a day rather than 3 times a day. You think that doctors will think, well, what's the difference? But to somebody in the real world, that's a huge difference. People remember to take it. We all forget about tablets. Just if you're taking 2 tablets and you're always taking 2 tablets, why not put them in a blister pack together? And it's stuff like that that actually makes a big difference to the extent to which people really take treatments in the real world. So we do a lot of work, and I think this is where foundation and patients can have a huge influence. If companies are talking about stuff like this, it doesn't really matter to them what blister packs they produce. They will have a punt at it. So if you can advise them on the best way of doing it for people's lives, it can make an enormous difference. So don't neglect pharmacy.
Great, thank you. Actually, the next question is about some of the new drugs and if there's going to be any trials done around people who've had recurrent PBC after transplant. So it asks particularly about seladelpar, but it could apply for elafibranor as well. Any trials will be done for people who've had recurrent PBC after transplant, or if not, whether it be suitable for transplanted patients to take it, and also if there'd be any concerns around that.
Yeah, okay. So short answer, no and yes. And a slightly longer answer, I think it's unlikely people will do trials of them, okay? And the reason is, well, twofold. One is recurrence is getting a lot less common because it's now standard practice to continue urso after transplant. So here's a simple message, okay? If you have a liver transplant, still take urso, okay? And that's based on a lot of experience. So all the centres in the world came together to work out what happened to their patients. And they showed quite clearly that if people continue to take urso after a liver transplant, recurrence rate went way down. You would never be able to do a trial of that because numbers of PBC transplants are a lot lower than they used to be, and the recurrence rate is very low. And you need to have years and years. You just can't do it. And I think if that applies to urso, it also applies to the other drugs. The trials that were done of elafibranor and seladelpar and OCA and things like that all excluded people who'd had a transplant. Mm-hmm. The reason for that was not that people who'd had a transplant with recurrent disease weren't important. It's that trials, you're looking for a homogenous group of people, okay? So you want people to be as similar to each other as you can so that the answers are generalizable, right? What then tends to happen is that once you have access to the treatments, you use them as you feel fit. So we're not constrained in normal practice, to not give them to people with transplants. In fact, we do. It's just the trial. So it's a methodological thing. It wasn't a sort of philosophical objection. So we certainly, we don't see as much recurrence as we used to, but we certainly use all of the second generation drugs in people post-transplant. I know Gideon in Canada has treated quite a lot of people with recurrent PBC, particularly with OCA. Comment I made earlier about just watch kidneys, because tacrolimus and cyclosporin in particular can affect kidney function. So kidney function after liver transplant is a kind of occupational hazard. And so I might just be a little bit sort of cautious about a fibrate. But if somebody meets the criteria for needing second line therapy, I would do that without hesitation. There's a caveat to that, however, is that there are lots of reasons why somebody after a liver transplant might have abnormal liver function tests that are not recurrent PBC. Okay, and remember, the diagnosis of PBC needs 2 out of the 3 of biochemical tests, the ALP-FOS, AMA, and a biopsy. Now, AMA stays elevated in everybody always after a liver transplant. It doesn't mean anything at all. It doesn't mean recurrence. It just, your immune system remembers, it's like tetanus vaccines work, don't they? Because the immune system remembers. So you will continue to have AMA. So therefore, that's not valuable. And of course, there are other reasons why your ALP-FOS might be elevated. It happens in lots of people after transplant. So you can't make an assumption it's recurrence. And so I'm afraid it tends to be something you need to do a biopsy to diagnose. And the danger is that you end up going down a rabbit hole if you don't do that. And of course, the other thing you've got to be really careful to is make sure it's not what you call preservation injury. So some of the injuries that happen to livers, whilst you're doing the transplant, can have bile duct effects down the line. So if somebody's tests are abnormal, we would have a very low threshold of doing what's called MRCP, which is the modern way of looking at. Mo will know all about this. It's the modern way of looking at the bile ducts. You do that at a drop of a hat, really, after a transplant, and then I would have a biopsy. And after that, if it really is recurrent PBC, I absolutely would use one of the newer drugs, but I would tend to go for probably OCA or seladelpar would be the ones I would go to for a variety of reasons. But don't be worried about recurrence. As I said, I don't think it should ever factor into somebody's. It's not a big enough issue. If you would benefit from a liver transplant, then and in everybody, the discussion is what's the benefit to me and what's the risk to me, individually. That's the balance you've got to look at. to me, risk of recurrence would never be sufficient to enter into that discussion.
And just when we were talking about potentially trying the new treatments, if you've got recurrence, could there be any effect on your anti-rejection medication, sorry? And how best would it be monitored? Would it need to be specially monitored or just monitored?
No, I mean, no, they're not drugs that particularly interact. They're not drugs that are problematic like that. Remember, I mean, tacrolimus, well, they're both tacrolimus and cyclosporin are blood level monitored. So you do have that safety net with them. I think common sense says, you know, if you start on a drug, and the thing about, you know, obeticholic acid, yeah, you know, we've got quite a lot of experience of it. Elafibranor and seladelpar are not, because by definition, transplanted people are excluded from the trials, as we said. Mm-hmm. You know, common sense says that cautious people, if you're doing something new or a combination of new things, then what you do is you see people regularly, do blood tests regularly. And once you've done that 10 times, you realize this. And the fact that we don't know there's an issue doesn't mean there's no issue. It means that we don't know whether there's an issue or not. So we're very cautious about these things. Transplant units are very cautious about people. And I think in our world, it's more difficult in things like heart disease, you know, where you've got to do quite invasive tests to look at what's going on. For us, you know, liver blood tests are really helpful. And, you know, if in doubt, repeat the blood test. If in doubt, you know, repeat the blood test, and just monitor it. And, you know, we see this, we get this, I mean, asked this all the time by other doctors, you know, this patient's got X, Y, and Z, I want to use this drug, you know, what's your thoughts on it? Well, my thoughts are, I'm not aware that anybody with PBC has ever had it. And what do? Do you say don't take it? Well, there's no theoretical reason not to. So what you do is you say, yeah, I think that'll be fine. We'll monitor whilst you do it. And then, you know, so, but I don't think I would worry about any of those. But I think some of the newer drugs can be very good for that.
Brilliant. That's great. Thank you. Next question. Does having PBC without progression to cirrhosis mean that an individual is greater risk for an infection with either COVID-19 or HS5N1 flu? Would concurrent type 2 diabetes under good control without medication make any difference to this answer?
Yeah, so PBC, there is no increased risk for non-cirrhotic PBC. So I think that the question has pulled out the key points, actually. So for non-cirrhotic PBC, there is no evidence of any form of increased infection risk, okay, full stop, with the caveat of one thing, which is urinary tract infections. Now, urinary tract infections are associated with PBC, and this was something that was observed a long, long time ago, and nobody quite knows which way the connection goes. So are people with PBC, so PBC patients are typically women, so women are more likely to get urinary tract infections than men are. So is it to do with that? Is it that PBC makes you more likely to get infections? Do infections cause PBC? Personally, I think it's PBC, you know, and thinning of the lining of the urethra is, I think that's the reason why. So I think it's PBC, things associated with PBC just predispose a little bit, but just be live to it. We don't do anything differently with it, but what we do is just warn people. And generally speaking, it seems that it may be that it takes a little bit more in the way of treatment to get on top of them. So GPs now, you know, want to wave, you know, an antibiotic tablet under somebody's nose for 30 seconds. And I do think we need to treat it properly. So this is advice we give to the GPs all the time. If people are getting recurrent UTIs, you're going to need to give a slightly longer infection course, you know, antibiotic course to eradicate. So urinary tract infections are more common. Other than that, nothing is more common. And in fact, we believe that these sorts of kind of infections in the community are less common. And you can imagine that, because if you've got an immune system which is hyperactive, which is what contributes to PBC, you could imagine how that immune system might be better at fighting infection. So we give no advice at all about, you know, infection risk and so on and so forth. Cirrhosis is different. Cirrhosis affects your immune response because a lot of immune cells are in the liver and they get pushed out when you have cirrhosis. So you do need to be more careful if you've got cirrhosis. Again, it's not a big risk, but you do see more. And this is, I think, where people got a bit confused about COVID, because the advice that was given around shielding was really about people with cirrhosis. And of course, as you will know from many of these sessions, the vast majority of people with PBC don't have cirrhosis. So this was yet another hangover from the dreaded word that was abolished from the name, is that people assume that people with PBC have cirrhosis, and of course most don't. So there was an element of fallacy about that. But if you have got real cirrhosis, then, taking other drugs, operations, infections, there's a bit more of a risk for all of those things. And type 2 diabetes is always an infection risk, and it is always reduced by the degree of control, but because it's about the way in which the micro levels of sugar operate, there is always a residual risk. And of course, type 2 diabetes is particularly a risk factor for urinary tract infections. So type 2 diabetes, you can't take away the infection risk by good control, but you can substantially reduce it. I think that's probably the way I would look at it. So infections are not a particular hazard at all with PBC, and we wouldn't give any particular guidance about avoiding them. Cirrhosis a little bit different. Diabetes, if it's there as well, will add to it. And just watch out for the urinary tract infection thing, because if you are getting them, it's important to make sure you eradicate them. And a little tip, if you get recurrent urinary tract infections, you just need to make sure it isn't the same one that's not been properly treated. So that's a reason to do another water culture. So if you put a water sample in to the doctor for culture and they come back saying it's whatever this bug is, and the symptoms come back in a week's time, sometimes people think there's no point putting another sample in. Actually, there is, because you want to know, is this the same bug that's a bit resistant to treatments, or is this a different one? Because the treatment is different in those situations. So our advice is always to do a culture, because it will guide what you do.
Great, thank you. Our next question is about cirrhosis, actually. So we've got someone who has cirrhosis caused by PBC that fluctuates between compensated and decompensated.
Yep.
What is the point of being on urso at this stage when the PBC has already advanced to cirrhosis? They understand the importance of diet and healthy lifestyle, but confused about continuing to take urso. Do you want to explain the difference between compensated and decompensated first?
Yeah. So what is cirrhosis? So cirrhosis is a combination of scarring in the liver and an attempt by the liver to regrow, if you like. So your liver is can constantly grow. Okay, so brain cells don't grow, kidney cells don't grow, but liver cells do grow. Okay, so if you were to have half a kidney removed because you had a tumor in it, for the rest of your life you'd have half a kidney. Okay, however, your liver, if you have half your liver removed, within about 3 months your liver will be back to the same size it was before. So it can regenerate, and it's to do with how it functions. One of its roles of liver cells is actually to soak up poisons and then die off, packaging those poisons up. So it's part of its nature. So the liver cells dying and regrowing is actually inherent in how it works. So if you've got chronic liver injury with scarring, the liver tries to regenerate, okay? But if the scarring is extensive, then it kind of ends up a little bit like bubble wrap. So you've got, think of the liver cells as the air in the bubble wrap, but you've got this sort of whole network of scar around it, which means that they really struggle to regrow. So those liver cells then regrow within those bubbles, but that puts pressure on the liver cells. Okay, so it's a disordered liver trying to regenerate, disordered because of scarring. And so fibrosis is where you've got scarring, but it hasn't turned into this network. And then cirrhosis is where it's a network. That's the important difference. Right. Now, your liver, most people on this call, your liver is 3 times the size it needs to be. That's because it needs to be able to soak up, extra work if you're ill for some other reason. So you've got plenty of reserve in your liver. So if you lose half of your functioning liver cells, it will not affect your liver function at all. And in cirrhosis, because you've got this disordered anatomy and pressure and things like that, you have less in the way of functioning hepatocytes, right? So it nibbles away at the amount of functioning liver cells you've got, but it initially nibbles away within that 50%, right? So compensated cirrhosis is where you've got the scars, the plastic of the bubble wrap, you've got hepatocytes proliferating, and coming under a little bit of pressure, but you've still got enough hepatocytes to have normal function. So it's cirrhosis with normal liver function and no complications. Okay. Decompensated is where you're running out of hepatocyte function because you've gone too far into that, 50%, if you like. And so you start to get a failure of liver function. And you also get other complications due to pressure. So if you have those liver cells growing within those bubbles, if you like, and they grow and grow and grow and grow, but the bubble doesn't stretch, there'll be pressure rising in it. And that pressure gets transmitted to the blood vessels, which can cause the portal vein blood pressure to go up. And that's what causes varices to develop. It's what causes ascites to develop. Okay. So those are all features of decompensation. Okay. Now, when the questioner said that it flips between compensation and decompensation, and that's exactly what you see. Why? Because if you've got 50% exactly, metaphorically, and you lose one hepatocyte, it tips you over the edge. So when people decompensate, actually, they're just usually tipping over the edge. And what you're looking to do is to tip them back to the right place. Okay. Mm-hmm. So we will every so often, I have to say it's uncommon these days, see somebody who comes in with a variceal bleed. Okay, that's a decompensation event. And what you'll usually see is liver blood tests deteriorate. Okay, why? Because the bleed puts pressure on the liver, which puts pressure on the function, and they get this cycle, right? You get this cycle. So that's what you tend to see. And people often be very worried about this. Some variceal bleed, and all of a sudden the liver blood tests that they've been worrying about so long get massively worse. And I always say, don't worry, it'll all come back to normal. When you jump into if you jump into a lake, you sink for a little while, after you've jumped into the water, but you will eventually, go back to the surface. And that's what always happens. You recompensate, right? Now, compensate. So you're better off not being cirrhotic. So you're better off not having any fibrosis. If you've got fibrosis, you're better off not being cirrhotic. And if you're cirrhotic, you're better off being compensated and not rather than decompensated. And if you're decompensated, you need to recompensate, right? So anything you can do to stop those disease state transitions, we call them, is a good thing. Now, remember, it's the straw that broke the camel's back is why people decompensate. And what does urso do? It protects the remaining liver cells. So it will prevent you from decompensating. It will not reverse the cirrhosis. It will not take away the scarring, but it will mean that you don't go from 51% to 49%. And actually, that can make an enormous difference. And actually, Keith Lindor, who's a great friend of PBC patients and of the PBC Foundation, published this donkeys years ago, showed that actually variceal bleeding rate was significantly reduced in PBC by using urso in people with cirrhosis, full stop. And that I've just given you the explanation for it. So you could argue it's even more important than it is in somebody with very early disease. It's just important for a different way. And of course, urso is very well tolerated and very easy to take. And for that reason, it's very good. Now, that's not true of the other drugs, actually. So people will be aware of some of the concerns about obeticholic acid and guidance about it. That's because anybody who's right on the edge, if you have too aggressive a treatment, you can, for instance, cause liver cells to swell a little bit. Now, this is well known in liver disease, is that sometimes the treatment to protect the liver can actually cause the decompensation. There are people who, amazingly, with cirrhosis in autoimmune hepatitis, for which steroids are a really effective treatment, can actually decompensate if you give them steroids. Okay, so you've got to be really careful in people on the edge. That does not apply to urso. Does not apply to urso because its function is physiological. So I think it's a very good thing to do. There is a really important point here. And obviously, this is where, I think this might be one for Mo and colleagues to pick up. If you are on the edge between compensation and decompensation, where are you with regard to transplant? Okay, because that is an absolute reason to be considering transplant. That may well have happened, or it may well be something you've thought about and don't want, or it might be something, where there's a reason you can't for other health reasons. But it's mandatory to be asking the question, okay? So the moment somebody decompensates with PBC, that is an absolute indication to consider transplant. Not an absolute indication to do transplant, it's an absolute indication to consider it. And sometimes, I hope this doesn't scare you, it's not meant to, it's a positive thing. I hope it sometimes people who aren't experienced about PBC and its little ways, shall we say, think it's a bit early to be thinking about transplant. Actually, they're used to people with viral hepatitis, which looks and behaves completely differently. And somebody that I would want to see to think about transplant would actually look a lot healthier and seem to have a lot milder liver disease than you would do for other liver diseases. Okay, so that's just an observation. And Mo, you're very familiar with all of this from the foundation, so I would encourage you to have a chat just to find out where you're up to, because you just want to make sure they aren't underestimating this. I once went and I do a lot of education stuff, but the patients, as we're doing here today, but also for clinicians, and you'd be surprised how many clinicians dial into these, okay, who find them informative as well. It's a good thing, right? I went and did a talk at a hospital where they wanted to learn more about PBC and particularly confident about it, and they presented a case of somebody. They presented a case and they wanted to know my opinion, okay, and we got to the end of the presentation and they said, should we give that patient a second-line therapy? To which the answer is no, they need a liver transplant, full stop. There is no discussion, there is no negotiation. They need a liver transplant. Obviously, I knew more about the details from the presentation about all of that. And they said, but shouldn't we just try that? No, I want you to leave this room and go and phone your liver transplant unit, okay? They hadn't thought about that and done that. And I went and caught up with them about a little while later, and that lady had gone to the transplant unit, had a transplant, and they said to me, I think you might have saved her life. And I think I did, okay? And I tell that story just because you sometimes need an outside pair of eyes to say no, 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 no. And for us, varicose bleeding, ascites, encephalopathy, jaundice, all of those are alarm bells. Not saying you need a transplant, but we would know in the Northeast, want to know about anybody with any of those abnormalities anywhere in our catchment area, so that we could decide how frequently we're seeing them. And if it is a bit early, then actually I quite like to talk to people about transplant early, because you can get used to the idea and answer questions and bring family members in. And often people have brought their kids in to talk about it, and it's just much better to have time to think about it and get your head around it. So will you pick that up, Mo?
I will. And just when you were talking about that, it's making me think about the importance of Project 1990 as well, isn't it? So that we're patients are correctly being monitored and there's no potential for that to happen.
Correct. And I think there are two steps to that. One is to do the monitoring, and then the other is to look at it and analyze it. And I have to say, I mean, we talk a lot about the audit that has been really important in terms of getting people to do things differently. And there were some worrying things, and this is about how PBC care was in the UK. And I'll be honest, that there were things about that were worrying. The one good bit was URSO, actually, interestingly. So the message has sort of got out there to give people URSO. We expected people to be a bit more unsure about second-line therapy. I mean, all these new drugs coming along, it's difficult for people to stay on top of it. One of the areas where people were worst was actually when to discuss with a transplant unit, which is, if you like, old-fashioned hepatology. And I think there is still work to do, okay? There is still work to do. Tricks of the trade, whenever I see a new patient with PBC, I will usually mention transplant, okay? And people think, well, that's bananas. Why are you mentioning it? Why? Because I'm telling people that I'm thinking about everything. And I'm also saying to you, you may read about transplant, you can forget about that. in this day and age, blah, 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 because I don't want them to go away and think, why didn't he mention transplant? This is something I'm not being told. So it's my way of saying, I think of everything in everybody every time I see people, but 99 times out of 100, you think about transplant and you discount it. That's not a reason not to talk about, to demythologize it.
Absolutely. And I think for us as patients,
I have a sneaking feeling that most people I see, kind of heading towards transplant just want to get the operation to stop me bloody talking about transplant. I firmly believe that. Okay.
No, I was just going to say, I think it's us as patients. I would much prefer the more honest conversation. Certainly, it's how my doctor spoke to me in the lead up to that.
I have a rule of thumb. I want people. I say to people, when you are wheeled down to the operating theatre. I went and had my knee replaced. I was wheeled down to the operating theatre. It's good that you are absolutely happy in your own mind that it was the right thing to do. No ifs, no buts, no questions. No, I'm not sure about this. You need to have done that being sure about it beforehand. So my wheeling down to theatre is the acid test. I have to tell you a story. I know this is getting off topic, but this will, on that note, is that I once met not a PBC patient, and I once met a chap. It was other form of liver disease that involved a more dissolute lifestyle, shall we say. And he went down for he had variceal bleeding, went down to the operating theatre to have an endoscopy for his varices. Okay. Anyway, so they all went through all of this, and he'd been somebody who'd been sort of, shall we say, resistant to lifestyle advice beforehand. Anyway, I saw him on the ward round, and he was a changed man. This is a true story. He was a changed man, and I'm going to change my life. I'm going to give up alcohol. I'm going to do all of these things. I absolutely am a changed man. Okay, and so I said to him, well, this is new. This is good. This is good. This is a new thing. What made you change your mind? And he said, well, I almost died. I almost died, and I saw the end of my life, and that's what's made me change. And I thought, well, that's slightly unusual. Anyway, it turns out, and this is a true story, it turns out that he was quite woozy with his liver disease and went down to the operating theatre. Okay, they press a button on the door, and these doors swing open. Okay, and he was wheeled in. And he was wheeled in, and the nurse said to the porter, "It's not his time. Send him back." Okay, and he thought it was the pearly gates that he'd just encountered. In fact, it was the operating theatre. But if it made him change his ways, that was one thing. Sorry, that was off topic. It's not his time. Take him back.
I'm just going to move over into the room here, Professor Jones. We've got a couple of questions around calcium and supplements, and then a follow-up question from someone else. I thought we could take them before we finish up.
Yeah. So,
patient who was quite ill from hypercalcemia, but okay now since stopped taking calcium supplements, and now avoid food with added calcium. Would you advise against calcium supplements because it's very plentiful in the diet? We'll start with that one.
Yeah, no, I think so. So you can see people with hypercalcemia. So hypercalcemia can be quite a subtle problem, and people can easily miss it. Okay, so when I was a medical student, they told you it was moans, bones, and abdominal groans. So it can cause you it can cause you aches and pains, depression, fatigue, actually, interestingly, and also bone pain. Okay. Now, you can get that with calcium supplements. You've got to be taking quite a lot. You often can get it with other medical conditions. So there are medical reasons why you can get it. In fact, most people in our society don't need to take calcium. It's the vitamin D3 you need, as somebody said in the comment. So it's the vitamin D3 that we're short of. The reason is that we live in a place, Mo's in Scotland, so she knows all about this. You're in a place where the sun never shines, and we sit indoors all day long, and then we go outside, we put factor 50 on. So we need sunlight to make vitamin D, and so we don't measure vitamin D in the clinic because everybody is short of it. So you do need vitamin D supplements. Most people, if you eat a reasonable amount of dairy product, are not calcium deficient. But it's actually quite difficult to get vitamin D without calcium. So that's where the problem arises. So calcium, if you drink some milk, don't need to drink much milk, butter, cheese, most people will have it. So try and take vitamin D3. And if you've had hypercalcemia, you absolutely shouldn't take calcium supplements again. Remember, magnesium is like calcium, but it doesn't get thought of quite as much. Okay.
Mhm.
So magnesium deficiency actually is quite common. My wife is an intensive care consultant, and she goes on about magnesium and all the problems of magnesium deficiency. So do think about that. You can get magnesium supplements. And so it's also worth thinking about. It's more difficult to measure. If somebody has hypercalcemia, I would always be a little bit suspicious, okay, if somebody had it just because they're on calcium supplements. So what I want to do is to stop the calcium supplements and then make sure it returns to normal of its own accord. So make sure there isn't something else potentially causing it. So you can in fact produce too much of a hormone that means that you produce too much in the way of calcium. So it's one of these things. It's likely to be the supplements. It suggests that you probably are taking too much calcium because you've got it in the diet. Try and take D3 without the calcium, but just make sure that it returns to normal without the calcium supplements. And watch out for magnesium. And it has some weird effects as magnesium. It reduces your blood pressure, for example. So it's actually a very effective way of controlling blood pressure. So just watch out for that.
Okay, there was the second question there with someone who had the opposite issue, but I think we've answered that as well, haven't we, around someone who needed to take extra vitamin D, and we've spoke about that as well. I just wanted to check we'd got everything there.
Mona, welcome to Louis. So hello in Louisiana. We like to collect, I saw your message earlier, we like to collect parts of the world.
We do.
So we like to collect travel the world with these. Yes, so North America is very interesting. So I'm endlessly fascinated by Walgreens and pharmacies in America. They have a much greater diversity of supplements and things than we do. Okay, it's very interesting. So I'm always to be found in pharmacies in America, drugstores, having a nosing around what you can get. Things like Q10 and things like that are very, very available. So melatonin for sleep is available in pharmacies, and so they have it. So clearly, Mona from Louisiana says she's taking magnesium, which is the message, which is a good thing. I don't know the dose. But like all of these things, don't overdo it. You're absolutely right. My wife is an intensive care consultant. One of the reasons they use magnesium is to help people sleep in an ITU, okay, where sleep can be often very difficult. And vitamin D deficiency is also a reason why people can struggle to sleep. So taking vitamin D can help with sleep. So those are where you're looking out for. So the answer actually to a pharmacist once told me that the correct dose of any treatment is 2 tablets or 1 ampoule of an injection, and it's a really good rule. So whatever the dose, whatever the pack size is in a pharmacy, then it's 2 tablets of that. But Mo, if you could sort of check that on, I don't know that one off the top of my head, but magnesium deficiency is more common than people think it is. Vitamin K with vitamin D. Vitamin K deficiency is, we're doing real-time questions here.
We are. And this will be how it'll go when we all move over to here. So that's great. Yeah, the interaction is brilliant. So yeah.
Deficiency is actually really uncommon in PBC. So the reason A, K, and D go together is because they're all fat soluble, and E, they're fat soluble vitamins. Okay, so you need to have fat in your diet to absorb them, and if you aren't producing enough bile acids, you struggle to absorb fat, and so therefore fat soluble vitamins can be a little bit short. The one that it's D that causes the problems because our levels of D are a bit more marginal. K and E don't tend to give deficiency. We always supplement, if somebody comes in with PBC for an operation, we would always give them an IV shot of vitamin K just in case there is a clotting issue, because vitamin K is for normal clotting. So that's what we tend to do. And I'm, as people will have heard me in these sessions before, I'm endlessly fascinated by vitamin A because PBC patients are often very short of it because of the fat soluble thing. And it's difficult to supplement it other than with tablets. And back in the day, when Sheila Sherlock was developing PBC management in the 50s and 60s, she used to give people intramuscular injections of vitamin D and vitamin A. And we don't do that anymore just because they're not available. Nobody makes them. But I was always sort of interested by that. And how important was that? And is vitamin A deficiency? So I always recommend to people take a good quality multivitamin. Multivitamin and minerals. So you'll go into any pharmacy or supermarkets. You'll see a variety of these. Have a look at what's on the back. Usually go for vitamins plus minerals because they will have some of the other things like the magnesium and zinc and things like that you need. And I think I would recommend to everybody to take that. I think for all of us, that's a useful thing. And then supplement specifically on top of that. Things like coenzyme Q10 that we often talk about, they aren't in multivitamins. You need to look for those separately. And if you are in America, on holiday, do go to Walgreens, and you'll probably find me there inspecting the supplements. It's endlessly fascinating.
Q10 available Amazon in the UK as well, if anyone's looking.
Yeah, so that's the other thing, is that's a very good point, is that it's one of the things that Amazon does really well, and they're very cheap. And so there are now the internet. You've just got to be a little bit cautious about some of the health claims. Do your background to it all. So you'll read this supplement changes the world and things like that. So be a bit cautious about that. But once you've decided what you want to take, these are usually absolutely generic. I mean, you can go to shops that sell expensive versions that is basically the same drug. And so this is where the internet is very useful. And there are some vitamin companies, but to be honest, you can get pretty much everything on Amazon.
Yeah. Just before we close,
including a very good book, I gather.
Yes, I have all three of them here.
Noticed that.
I have all three of them here, yes.
Including the first ever copy of the 3rd edition autograph.
I do, yes, which was handed to me personally in San Diego last year. Yes, I have it here. So yeah, we love Amazon for that reason and that reason alone. Just before we go, I just wanted to mention we've put some calls out on socials this week. It's Rare Disease Day tomorrow. And we put some calls out on social for anyone who wants to share their stories. We have received quite a few, but if anyone would like to do that, please get in touch with me. My email address is on the website article. It's mo@pbcfoundation.co.uk. Rare Disease Day is also my birthday, which is tomorrow. So it's always an important day. And it's good that in the lead up to Rare Disease Day, we share a lot of information about rare diseases itself, but also then we close in on PBC as we get into the week of Rare Disease Day itself. So please, there's lots of information on our website and on our socials this week. So please get involved in that and share as well.
Just very quickly on that note, so there is a big focus on rare disease internationally. Certainly in the UK, there is. I'm quite involved in all of that. Rare Disease Day is part of that. Remember, though, that not all rare diseases are the same. And that there are sort of two big splits that are very important. One is the difference between what you might call common rare disease and rare disease. Okay. Mm-hmm. Now, PBC is a very common rare disease. So it is a rare disease, but it's right at the common end of that. Now, if there are 100 people with a rare disease, how do you manage those people? Well, they all travel to a single specialist clinic that manages all of them. But we have 22,000 PBC patients. So the challenge is very different. So on days like Rare Disease Day, we need to remember that how you deliver the effective care to everybody differs hugely between very rare diseases and common rare diseases, because a solution that works for very rare disease, arguing for dedicated clinics that people can go to, that's a very different thing, for a common rare disease. And we've got to have more natural thinking about care delivery systems and, online decision support and things like that. Okay. And then the other thing that Rare Disease Day can sometimes focus on is genetic diagnosis, genetics. And of course, some rare diseases are genetic in origin, PBC isn't. And so a big drive on making sure everybody can get a genetic diagnosis means literally nothing to anybody on this call, because it's not a genetic disease, and though genetics doesn't play a part in that. So one of the arguments that I spend a lot of time making those points is that all patients with rare disease deserve a fair deal. And you don't make it fairer for you don't make it fairer for some disease areas if you ignore those areas and only make it fairer for other disease areas. So with all due respect, people in PBC I find are very caring, but you are mainly interested in PBC. And if miracle cures for somebody else is something that you might feel good about, but not nearly as good about as you'd feel about if it was a miracle cure for your daughter. So we have to remember that rare diseases come in lots of different flavors, and how care is delivered will be very different for them. And we have to sort of remind that of people. There are some very good people in politics at the moment who get this. So Wes Streeting, this is not a party political comment at all, because we deal with governments. Governments come, governments go, we deal with governments. Wes Streeting gets this, we think. We've had discussions with him. So he's the challenges of how we do this. And there is a very nice lady called Liz Twiss, who is a Labour MP for somewhere, just south of Newcastle. She has a family connection in rare disease, and she chairs the All-Parliamentary Rare Disease Group, which is a group of MPs who are focused on rare disease, and she really, really gets it. Mm-hmm. And so she's a good person too. And she's very proactive about, helping support in rare disease. And so those are good people. If you have the opportunity to come across them, and if we do happen to have anybody on who's in there for whom they're your constituency MP, then, and I think when I worked in Department of Health for a number of years, and my observation of it is that despite all appearances to the contrary, they are basically good people, and they just don't always know what the right answer is. And if you help, so rather than complain to them, if you can help them understand what the right answer looks like, it's much more productive. And there are people who are, I found both of those very interested in finding out what the issues are and what the solution might be.
Yeah.
And on that note, very enjoyable session as always.
It was a great session. I just wanted to say the foundation did have the opportunity to speak at the Scottish Parliament at the end of last year, which was amazing. And it was definitely the approach of raising awareness rather than complaining.
And educate them and help them.
Are you supposed to be somewhere? Or you need to go?
Yes. See you later.
You're told. Right, next time. See you later. Bye, guys. Bye.